Welcome to the 260th of the COVID calls. This is a daily discussion of the COVID-19 pandemic with a diverse collection of disaster experts. My name is Scott Gabriel Knowles. I'm a historian of disasters at the Korea Advanced Institute of Science and Technology. I'm coming to you live from Daejeon, South Korea. Today, I'm glad to welcome vaccination expert Samantha Vanderslot to COVID calls. She's part of the Oxford Vaccine Group. Just a reminder, you can catch COVID Calls live most weekdays at 5:30 p.m. Eastern Time on YouTube. Just go to the COVID Calls YouTube channel to watch. You can also hear COVID Calls anytime, recorded as podcasts on Spotify, iTunes, Podbean, or anywhere you get podcasts. You can keep up with COVID Calls via Twitter using the handle @USOfDisaster or @COVID Calls. Please help spread the word and send suggestions for future guests and future topics, and please feel free to suggest yourself as a future guest. As of today, April 15th, 2021, there are 2,975,875 deaths globally from COVID-19. That's according to the Johns Hopkins University Coronavirus Resource Center. Death toll in the United States from COVID-19 today is 564,387 people having lost their lives from that disease. In the United Kingdom, 127,161 deaths have resulted from COVID-19. In Australia, 910 have died. As a way to bring some humanity to the numbers, I've been reading a life story or a story of advocacy for those impacted by the pandemic in some way, and I'd like to continue that now. The headline is HIV/AIDS researcher David Katzenstein dies. This is from Stanford Medicine News Center by Bruce Goldman and appeared on February 4th, 2021. David Katzenstein, MD, Professor Emeritus of Infectious Diseases and Global Health at Stanford Medicine, who spurred advances in diagnosing, treating, and preventing AIDS, died January 25th of COVID-19 in Harare, Zimbabwe. He was 69. Katzenstein was a trained virologist, clinician, and tireless advocate for global health. He was widely praised for his energetic push to bring better, cheaper methodologies to bear on HIV/AIDS prevention and treatment in middle and low-income African countries, where over a 35-year period he spearheaded numerous life-saving projects. Imbued with a passionate belief in social justice, David Katzenstein had an outsized impact on the fight against HIV in sub-Saharan Africa, said Lloyd Minor, MD, Dean of the School of Medicine. The Stanford medicine community is grieving his untimely passing. We will miss him immensely, he said. Colleagues described him as a renowned laboratory scientist, brilliant thinker, stellar mentor, and overall optimist. It's hard to visualize David's face without a smile on it, said Julie Parsonet, MD, Professor of Infectious Diseases and Epidemiology and Population Health. Parsonet, the George DeForest Barnett Professor in Medicine, arrived at Stanford in 1989, as did Katzenstein, and worked closely with him on a number of projects dedicated to reducing HIV transmission in Zimbabwe. He was creative, electric, Parsonet said. Ideas would just come shooting out of his head so fast you couldn't keep up with him. As longtime associate director of Stanford's AIDS clinical trial group, Katzenstein oversaw influential clinical trials of AIDS antiviral therapeutics. He was one of the first researchers to call attention to the problem of antiviral drug resistance in Africa. Born January 3rd, 1952 in Hartford, Connecticut, Katzenstein earned a bachelor's degree in biology in 1973 and a medical degree in 1977, both from the University of California, San Diego. He interned in internal medicine at the University of New Mexico, where his work with indigenous tribes instilled in him a deep desire to combat infectious disease among underserved populations. He completed his residency in internal medicine at UCSD in 1980, along with a fellowship in infectious diseases there in 1981. In 1982, he was appointed assistant clinical professor of infectious disease at the University of California, Davis, and in 1984, he accepted an assistant professorship of infectious disease at the University of Minnesota. In 1986, he departed for Africa, where he served as a lecturer at the University of Zimbabwe's Godfrey Huggins School of Medicine. Between 1987 and 1989, Katzenstein worked under Anthony Fauci, now chief of the National Institute of Allergy and Infectious Diseases, as a senior research fellow at the Food and Drug Administration's Laboratory of Retrovirus Research, Biologics Evaluation and Research. Katzenstein began his tenure at Stanford in 1989 as a clinical assistant professor of infectious disease, as well as the associate medical director of Stanford's AIDS Clinical Trial Group. With his colleagues, he conducted multiple studies, ultimately leading to the approval of life-saving antiretroviral drugs that greatly improved the survival of people living with HIV. From that point on, the problem of HIV drug resistance occupied a significant portion of his academic endeavors. David's major strength was in his scientific imagination and his sharing of it with friends and colleagues, said Thomas Merrigan, the George E. and Lucy Becker Professor of Medicine Emeritus, who, as then chief of the Department of Medicine's Infectious Disease Division, recruited Katzenstein to Stanford. He did this in a wonderful, warm manner, which made him a great mentor, friend, and leader of our group. In a hiking accident in Big Sur in 2009, Katzenstein plunged 90 feet into a ravine, sustaining a compound leg fracture that required 17 separate surgeries. The bone became infected and never fully healed. Initially wheelchair-bound, he walked with a cane for the rest of his life. Undaunted, he resumed his work with characteristic zeal. His desire to cure and prevent infectious disease in developing countries grew. With the success of long-term antiviral drug treatments, AIDS was now relatively well under control in the United States, Parsonet said. But those drugs were expensive. David was driven to find ways of bringing their benefits to less affluent populations, and he missed Zimbabwe. Katzenstein moved to Zimbabwe immediately upon retiring from Stanford in 2016. As director of the Biomedical Research Training Institute in Harare, he introduced state-of-the-art molecular diagnostics and disease monitoring to Zimbabwe's community-based treatment programs and trained people in clinical research. He remained extremely active and continued publishing papers until he fell ill with COVID-19. Katzenstein co-authored nearly 300 peer-reviewed papers and patents, awarded to Stanford for the use of the molecular technique called polymer chain reaction, or PCR, in identifying HIV-resistant variants, determining the choice of AIDS therapies, and monitoring patients' response to antiretroviral drug combinations. In 2000, the Doris Duke Charitable Trust awarded him its Distinguished Clinical Scientist Award, a 5-year grant underwriting his efforts to foster affordable treatments for HIV-infected women in Southern Africa. Okay, I'd like to turn to my conversation for today. Let me introduce my guest, Samantha van der Sloot. Samantha is a university research lecturer at Oxford Vaccine Group, University of Oxford, UK. Her research is about people's attitudes and behaviors towards vaccination. She draws on perspectives from sociology, history, anthropology, global health, and science and technology studies. She is particularly interested in public policy and media representation, as well as making comparisons across countries and time. Samantha van der Sloot, thank you for making time to come on COVID Calls today.
Thank you for having me, Scott. I've been following COVID calls, so I'm glad to join on one.
You get the award I give from time to time for staying up late to talk on COVID calls. I really appreciate you taking that time.
No problem.
So I'd like to start the way I usually do, just find out where you are calling from and how the situation is there with both the pandemic and also the vaccine.
So I'm calling from the UK, and I think there are some similarities here to the US and other countries where restrictions are starting to lift, even if indications aren't showing that that's necessarily a good thing to do. In the UK, the cases and deaths have been dropping quite sharply, so you can see why the government has wanted to loosen those restrictions now. So this week, the shops that were non-essential have reopened, pubs and restaurants have reopened for dining outside and drinking outside. So this is all very, very recent. I haven't really gone out the house this week, so I don't know, but I'm sure I'll find out later on how that's all changed.
the the idea is that people have that there was a threshold and the case rate has reached that now, it's dropped to that point, and that people's fatigue can't be pushed any further.
Well, actually, in the UK, it was interesting because we had this roadmap. So there are certain dates where, as long as the indicators, like you say, were looking like they're going in the right direction, we'll follow through with those particular dates to loosen restrictions. So that's what we had from Monday this week. And then the next one will be the 17th of May when the restrictions loosen further. You can go indoors and things.
And if someone wants to be vaccinated today in the UK, can they do that on demand?
No, so it's by age group at the moment, and over 45s have been asked to book their vaccinations. I think the site crashed on the first hour of that being announced. So there is demand. Yeah.
So is that done through some sort of a centralized system, or it's done in a decentralized way, the booking?
It's centralized. So the one benefit here of having the national health system is that everything is going through one system and you don't have to deal with different providers. It's being organized quite centrally.
That will come. I mean, Americans who have been calling all around, chasing around to different drugstores, showing up, haunting places at closing time to find out if they can get a dose that's left over. The idea that it could be centralized is a little astounding, I think.
Yeah, I think you can see the countries that have these centrally organized systems have found the rollouts easier. Yeah, and the UK's done quite well.
You shared with me that you also had COVID and that you've had some, what you might call long COVID symptoms. I wonder if you wouldn't mind sharing your experience with us.
Yeah, so I had COVID in October, and it was like a lot of people, quite a long illness. You don't tend to get over it very quickly. And then the symptoms really just lingered. And for me, that's mainly been headaches and fatigue. And then throw in some shingles last month as well for fun.
How did you find out that you had it? The symptoms presented themselves and you thought, this is it?
Yeah, I had symptoms and they weren't so obvious. So I didn't have the cough, I didn't have the fever, but I had a strange headache. And I thought, this is a bit weird. And I know the headaches are a sign of COVID. So I thought I'd get tested. And it didn't initially show that I had COVID, but my partner, he was positive. So I isolated as well. And it was only afterwards when I had an antibody test that I found that I definitely did have COVID.
I see. And as far as the long COVID symptoms go, is it very hard to get treatment? I mean, I don't even know what kind of treatment you would seek, but are you able to be seen by health providers and have that dealt with?
There is help in the UK. So you can go to your general practitioner. So that's like the family doctor, your local doctor, and they should refer you to a long COVID clinic if it's necessary. At the moment, I've been trying to just see how I'm going and try to rest. And it does seem to be improving very slowly. So I'm hoping I won't need to have any treatment following up.
Well, thanks for sharing that sort of personal story of your own experience. You are a person who's studied vaccination from many different vantage points. And I wonder if we could start by talking a little bit about the work you've done pre-COVID, the kinds of cases that you've been interested in, that you've written about. I know you've written about polio a little bit. So I'd like to hear sort of some of those reference points that you had coming into your thinking about COVID.
I think I'll start way back with my PhD because that offers some parallels with what we're looking at the moment. So what I researched was neglected tropical diseases. So a bunch of diseases that affect the communities in poorest regions of the world. And these diseases had been neglected, as the name would suggest, for a long time. They didn't have a lot of attention and funding. And what I was interested to know was how did this story change? So now they are getting a lot more attention. There is funding directed at them. So it's really quite a diverse group of parasitic, viral, bacterial, protozoal diseases. And there had to be quite a huge advocacy campaign to raise their profile. And kind of the ultimate sign was being included in the Sustainable Development Goals as diseases that would be given attention. So that was my PhD, and people weren't really that interested in talking to me about that subject, I have to admit. So when I started my postdoc, which was about attitudes to vaccination, I did see a lot more attention, both from the academic community and media as well. And you can just see the difference in interest between these two topics. And that's what I was working on pre-COVID. So I was worried about measles outbreaks in Europe and the US just before. And I think it was actually an indication of what might be going wrong in our health systems, that preventable diseases were seeing outbreaks. So maybe that was also a warning sign before we had COVID and the pandemic.
I wonder if you could say a little bit more about the neglected tropical diseases. I had a chance to talk with Dr. Peter Hotez earlier in the year. He's in Texas, and that's was his area, has been his area. And he described a really fascinating and I think ultimately to me pretty depressing situation that in the world of virology and developing vaccines, there's sort of superstar diseases, and then there's others that kind of get left behind, and he spent a lot of time fighting for funding, honestly, to try to take those on. It's not the way I conceptualized it. It shows how naive I was in my thinking about how vaccine development works.
Yeah, I mean, there's been more attention from the global health community towards these big three diseases: malaria, HIV/AIDS, and TB, tuberculosis. So that's been where the donor community has concentrated on. And then you have also the private sector who are just not interested in any of these things. And it's things like cancer and more profit-driven diseases that they tend to focus on, where they have markets for. And that's just not the case with neglected tropical diseases.
And you mentioned measles vaccine hesitancy in Europe. I'm more familiar with the US case. What has been the situation with that?
So, I mean, we have a longer history with a scandal about the MMR vaccine back in the 90s. And that's a story that just doesn't really go away. So there are lingering fears about a connection with autism and the MMR vaccine. And that, with the internet and with misinformation, that is something that does keep reappearing. At least in the UK, the MMR uptake rates really have recovered from that scare in the 90s. But you do see where there are small drops in uptake. You could have quite high overall uptake that can still cause outbreaks, especially from imported cases. And that's what you also saw in the US. Even though you'd eliminated measles, it only takes one unvaccinated person to go abroad and then contract measles abroad and bring it back.
I mean, even as you're describing that, it impresses upon me how fragile that, the thing we take for granted, that those are just diseases of the past. But you're describing, something, a case in the 1990s with some tenuous, unfounded connection ultimately to autism. And then that still percolates through the internet and still resurfaces. Yeah,
exactly. I mean, you are relying on people's trust in the governments, in pharma companies, in the health authorities. And that's something that is ongoing and will see knocks to it. So we just can't rely on having high vaccine uptake now. To have it continue, you really need to have very good immunization services and also general relationships with the government and the political system need to inspire confidence in the vaccinating publics. So you can even see seemingly unrelated non-health topics affecting people's willingness to vaccinate. And possibly the Ukraine is one example where a difficult political environment and an unstable country can cause lower uptake.
Are we seeing that there right now, or have you seen that since the war there had started?
Yeah, it also was connected to a health system that really hasn't been very suitable for the population. In theory, vaccination, for example, should be free, but it's not in practice, and people find it hard to navigate the health system there, and it just leaves them, the population, quite vulnerable for misinformation, for rumours about vaccines as well. And there's often, as we saw in the Ukraine, a trigger event where a child had died and it was connected to the vaccine, but then later found out not to be. And that kind of incident spreads fear and concerns about the safety about vaccines, which do rely on this trust.
You had a piece that you published in The Conversation back in September, or in COVID time, about a decade ago. But
Yes.
And it was just as the vaccine rollouts were imminent, and there were some really great scholars, yourself included, writing just at that moment. I thought really doing important due diligence that scholars can do to try to bring historical cases to bear on the present. I'm just going to read a sentence from that towards the end. You concluded, you're writing about the history of polio. You say the acceptance of vaccines is fragile. So when leaders promote their country's vaccine with clear political motivations, it can knock the public's confidence and draw intense scrutiny. As with the polio vaccine of the past, the world is watching. Can you tell us a little bit about that polio case? I think it's really interesting and instructive to our own time.
Yeah, I think polio is very interesting, right from the trials that went on to find a polio vaccine and to make sure it was safe and effective, as we've witnessed the trials for COVID-19 vaccines. And what was interesting there was the huge level of support for a vaccine, almost quite similar to what we've seen with COVID-19. And then as a vaccine was being developed, there were shocks, and shocks to do with the safety of the vaccine. And I think even I'm guilty of thinking once we have a vaccine, everything's going to be fine. But we know from past experience that you will face challenges. And at least with the polio case, it did result in regulatory changes to make sure that better safety checks were carried out. And now we can be quite confident in our checks and balances that if there are safety signals being flagged up for a vaccine, that there will be action taken. And that's certainly what we've seen with COVID-19 vaccines.
Just a reminder that you're listening to COVID Calls, and I'm talking with Sam van der Sloot of the Oxford Vaccine Group today about vaccines and vaccine hesitancy. So maybe you can give us the landscape view of the UK in terms of any part of it we want to start with. I think the vaccine development has been a pretty extraordinary story globally, but also the kinds of concerns that you're tracking in terms of uptake and hesitancy there in the UK.
Yeah, I actually want to just have a note about some of the other vaccinations that are going on, the routine childhood vaccinations, because actually that's normally what I'd be paying attention to. So what's unusual with COVID-19 vaccines are that you're vaccinating an adult population and starting from really the oldest going down. And that hasn't been the case for previous research on vaccine attitudes. So we've been more concerned with what parents think and their decision making for children. So in relation to those childhood vaccines in the UK, it's a bit surprising that uptake has been quite high. and that's continued through the pandemic. And this is something that a lot of public health researchers were quite worried about, that this uptake might fall for diseases like measles, and we might see outbreaks of those other diseases. And at least that's something to be quite pleased with, that uptake has remained. And it may be because the threat of disease is on the top of people's minds. And also, this is something that health providers have thought of as a concern, and they have wanted to remind people that it's still important to take those routine vaccines. And I think, sorry, go on.
Can I just pause on that for 1 second, because that's a really fascinating wrinkle to this. And that concern would spring from the fact that parents would be worried about taking their children into clinical settings to be vaccinated, or some sort of broader concern that they just are thinking about vaccines in a critical way for the first time in a long time, and so it raises concerns that maybe hadn't been there before, some combination of other elements?
So the worry was mainly that parents would be worried to bring their children into the clinical setting. And I think the arrangements were made to reassure parents that it would be safe to do so. And we've seen quite a change in how doctors speak to patients in the UK. So now it's become the norm to speak on the telephone, at least for a first appointment. Obviously, things like vaccination, you will need to go in to get that done. But I think patients have been reassured that healthcare settings are safe places, at least in your local clinics.
So that kind of data is reassuring, I suppose. But now we have households where parents are thinking about their kids, but at the same time, they're making their own decisions about their own health. And so how do you map that in terms of thinking about, targeting populations and communication and public health communication at this time? Who are you worried about?
So we're more worried about the younger age groups now, because it was quite obvious from early on that there was a higher support from the older populations who saw a greater risk of having COVID. And now the persuasion has to be with younger populations why they need to be vaccinated. And the reasons put forward for that are, well, it's still a dangerous disease for younger people, especially if we consider long COVID as well. And we don't know the long-term effects of COVID. It's really an unknown risk. And then it's also protecting others and bringing an end to the pandemic. So these are the messages that need to be got across, but also allaying any fears about safety and addressing misinformation that's going around.
It's particularly difficult considering that the messaging throughout the pandemic has been young people can't get this, young people can't get this. I don't know if that discourse has been as strong in the UK, but certainly in the United States through last fall, in the strong desire that I think is pretty broadly shared, but the strong desire for kids to get back in classrooms. Any pushback on that? The Trump administration was very angry and felt like people were not paying attention to the science as they interpreted it, and that this is not a disease that young people can get. So I wonder how that plays in and of course, what is a young person? That's subjective, but this younger population hearing those messages all year, maybe they think, yeah, I can't get this.
Yeah, I think this is really what's coming across, and it will have to be a different kind of messaging campaign for the younger groups. I think we can't rely on the messages that have gone out before, also in the UK.
What kind of messaging works with younger populations in vaccine?
So there are varying strategies. I think what we've seen is the argument about protecting others doesn't always have the effect that you think it will. So people do tend to think about their own individual benefit first, but connecting being vaccinated to ending the pandemic could be a more powerful strategy and bringing life back to normal. And I think almost showing the outcome of being vaccinated in terms of what freedoms could be introduced would be something that could work there.
I'm curious if you could say a little bit more about how you do this kind of work, because I think the term vaccination hesitancy is used, and as if it's an off or on, a yes or no. But my sense is that people have complicated and often contradictory ideas, that they may even trust one vaccine and not another, for example, or as we're seeing with COVID-19, there's multiple brands out there. And so they're trying to gauge their confidence in one or another brand. So I guess my question to you is almost a methods question. How do you go about finding and assessing someone's likeliness to trust a vaccine or not, and how that might change over time?
I think we do face a methodology issue within the vaccine attitudes area. And this is because we're either relying on really big surveys, cross-country or national surveys, or focus groups, individual interviews, and maybe more targeted interventions in psychology. This is something that's tried out. But then so you want to get somewhere in the middle of the two. And it's just more resource intensive and detailed work to be trying to do both of those micro and macro types of research together. And I think this is where some of the more combined and mixed methods studies I think are really useful, and where you're not just separating between topics like what is the uptake, but linking that to people's attitudes as well. So you might see, for example, the public health, epidemiology, demographer researchers being more interested in that larger scale attitudes and uptake research, and then maybe more qualitative research like me doing the interviews and the focus groups. But I really think there needs to be more interdisciplinary work so that we're combining our approaches and having overlapping questions that would be useful. So that's my hope for research in this area going forward.
It's interesting. So those are often conducted separately. I mean, that you find teams of qualitative researchers who do these smaller sample size, really intense interviews, and then we've had this much larger public health surveys, and the two don't cross.
Yes, you do tend to see that, and I think it is through the methodology, and unless you're getting bigger funded projects where there might be that opportunity to work across different fields. Otherwise, individual researchers will stick to their methodological area. There are exceptions, but I'd like to see more cross-working.
Is this the kind of work that you're engaged with? I mean, should we envision you as one of the people in one of those focus group rooms talking to 6 or 8 people about their experiences with vaccination?
Yeah, I hope I can be involved more in these bigger cross-disciplinary projects. And I know this is something at my university that they're trying to do is across my faculty, which is in medical sciences. They're looking for all the researchers working on this kind of similar topic to see if we can start working beyond our silos.
Working beyond the silo is of course, we all know is a huge problem in the areas that COVID touches, and it's a problem. It's like a double-edged sword, because on one hand we like the specificity of the tools that people have developed in their particular disciplines. It allows you to ask tough questions and get answers, but then sort of moving it up one level into sort of understanding how society is working, or understanding sort of outlying cases, it makes it harder. I wanted to stick with this hesitancy issue a little bit. Maybe you can explain, because it's been on my mind a lot that, again, I don't think it's so clear that people are hesitant or not hesitant. I think a lot of people who are hesitant still get vaccinated, right?
Yeah, this is definitely something you can see when you look at country survey data, which is trying to find out confidence levels in vaccination. And this doesn't neatly map onto uptake. And a lot of the time you do see that a country that has a high level of skepticism, like France, 40% of the population being skeptical of vaccines and their safety, importance and effectiveness, and they still have quite high vaccination rates in the 90%. Sometimes that's not always ideal. I mean, for measles, you want to have over 95% of vaccination rates, and that was partly why France strengthened their mandatory laws about vaccination, because they were worried about even these very small drops.
It's a really extraordinary statistic you just quoted. So 40% of people in France report that they have some concern about the vaccine. I don't know, are you referring to COVID-19 or previous other cases?
This was previously, but similar figures have been noted for COVID-19 as well, especially with France being the most skeptical and the least likely to have the COVID-19 vaccine.
A skeptical nation. I mean, it's really extraordinary to see. So that really captures it, right? And I wonder about that, and I don't know if you have the data to support this, but I wonder about stress in that situation. And this is just anecdotal, just me consuming news. But a lot of even major news figures, I was listening to Rachel Maddow the other day, and she was describing on air, she was talking about having received a dose, and then some of this reporting about AstraZeneca had come out, and so she was monitoring and thinking about it, and she had some concern, but it wasn't going to, ultimately she came down on the side, she's glad she'd done it. But I thought in her discussing that, she was talking about anxiety.
Yeah.
And is that the kind of thing you can account for in the studies that you're doing?
So, for example, I think the uncertainty does create anxiety, and you do have reports of when people are weighing up the differences between vaccines and trying to decide whether they want to vaccinate, even if they ultimately do, it's a difficult emotional process. But what we have seen is that the confidence has improved as these vaccines have rolled out, but with the exception of questions about safety now knocking individual vaccines like the Oxford AstraZeneca vaccine and now the J&J vaccine. So yeah, we see quite a variable picture. As more information has come out and people are used to seeing vaccinations happening and they know people who are being vaccinated, I think this all contributes to having less uncertainty and being more willing to be vaccinated. But then on the other hand, as we see safety concerns, as you might expect with a new vaccine, this isn't unprecedented. That does knock confidence in those individual vaccines mainly. We don't see a spread across vaccines as such.
I wonder how you assess this situation with the AstraZeneca or any of the other COVID vaccines where there's been sort of national level scrutiny that's been applied in the United States. I just read that in Denmark, taking their own action to slow adoption of the AstraZeneca vaccine. Are you worried about this, or is this a sort of something to be expected in the early phase of a vaccine rollout, that there will be, side effects linked or tenuously linked, and that just has to work itself out? I'm worried because particularly the earlier cases you were talking about, it seems like something can stick in the public's mind, and then science can come along later and say, actually, those two are really not, there's no causality there, but it's too late, that somehow it's stuck into public consciousness. Are you worried about that with these COVID-19 vaccines?
Yeah, I think when there's a fear that gets out into the public domain, and even if it's debunked or we find ways to manage that well, for example, if a safety problem is found to a vaccine, you will see steps being taken to try to mitigate that as much as possible. But that doesn't mean that the original fear and concern will be out of the public domain. So that is a major worry. I think what was also quite interesting were the different national coverages and also attitudes to individual vaccines. And we've seen this with the kind of quick polling that's been going on, what different nations think about individual vaccines. And the UK did have a very high support for the Oxford AstraZeneca vaccine until quite recently, but that was in opposition to other countries in Europe, and that depended on what our government was saying and how the media was reporting these events.
But do you assess that in the realm of politics? I mean, with Brexit and everything else, and the tensions that have been going on between the UK and EU and individual countries. I mean, I don't want to make this too simple, but I do wonder about that maybe, people in Europe who are already consuming a steady diet of anti-UK or hostile news coverage, how could they differentiate that from this AstraZeneca concern?
That was definitely the rhetoric going on at the time. And I think the political environment is really affecting public attitudes to vaccination, and maybe much more than I would have expected. Maybe I should have expected this, but it's I think in my field of research, we're often saying vaccines are rarely just about vaccines themselves. They seem to be able to engulf so many other issues within society and politics. And this is exactly what we've seen with the current pandemic.
Having said that, you must be fascinated with the numbers being reported in the United States. That I saw a story yesterday, 50% of Republican men in the US saying that they're hesitant or they won't be vaccinated. And it's not even so much there, I don't think it's, and again, I mean, those numbers it's hard to parse that. I'd need to know more about the study, but it's not always, doesn't seem to be rooted in some idea that the vaccine doesn't work. It's something else. It's just, I'm not going to get it, or I don't want the government telling me what to do, or any other factors that are overlaid with this sort of pro-Trump Republicans.
I mean, this is something that seems really quite different with COVID-19. So there hadn't been many studies showing that your political orientation affected how you vaccinated. That really wasn't a strong current before COVID-19. But when you do have high-profile politicians not being in favor of, say, health measures and public health measures in general, this does seem to be feeding into being against vaccination. And a lot of the discourse about and debates about opposing vaccination has also stemmed from being opposed to wearing masks and other government control measures.
So if people have deeper ideological commitments that override what public health officials are going to tell them, is there a way through that? Is that a matter of time? I mean, asking somebody to give up their political identity, waiting for that to happen, for them to then lose their hesitancy for a vaccine.
Mm.
You may be waiting a long time with some of these political commitments, at least in the United States.
Yeah, I think this will be really tricky, and it's likely to be an ongoing trend. I think we're not going to see the end to a political sway to being vaccinated. I suppose before COVID-19 happened, one phenomenon that we'd witnessed were populist parties using the idea of vaccination to win votes, really. So populist parties opposing mandatory vaccination and being in favour of leaving these rules behind if a country did have those kind of coercive policies.
You mentioned mandatory vaccination, and that's what's often used in these in the heated rhetoric, if it becomes politicized. That I'm talking about the United States here. That what's going to happen is people are going to be forced to carry a vaccine passport, and the government will now intrude. So it comes from a political position that is critical of what is seen as a centralized, overwhelming government presence in people's lives, and see the vaccine as just one more case in that. And so maybe we can talk a little bit about the mandatory vaccination concern as part of that. How common is it in the UK or other places that you study that vaccination becomes mandatory?
So what I think is quite unique is how much it comes up in conversation. At least so in the UK, we did have mandatory vaccination for smallpox about 200 years or so ago, and that didn't go down so well. And there was opposition to those laws, and vaccination became recommended. It did mean that when more vaccines were introduced, the government had to make more of an effort in the 40s and 50s to compel people to be vaccinated, but not through compulsory laws, but through public health campaigns and education and almost a marketing of vaccines. So that's been our history in the UK, and I think even though mandatory vaccination is talked about, there aren't really strong indications that that will happen. There isn't a high public support for that kind of intervention, and also the public health establishment isn't very strongly behind it. So it seems to be something that politicians like to bring up now and again as an option that they'll consider. And this has happened again with COVID-19, but it doesn't have much teeth to it. And I think in the UK it's quite unlikely. In other countries, I mean, we've seen now in Europe, France, Germany, and Italy, they did introduce types of mandatory vaccination policies against the outbreaks of measles that were happening in the last few years. So their policies were mainly about strengthening existing types of mandatory policies that were already there, with the exception of Germany, which was only targeting one vaccine, so for measles. So the idea that we might have COVID-19 mandatory vaccines across the board in many countries, I think that's quite unlikely. And whether a government wants to get into that territory at the moment, I think that's something that they really have to consider quite long and hard about. And yeah, the public reaction is something that they will be worried.
Is that something that, legally speaking, could be done even in the UK? I mean, this is a matter of in the United States, it would be handled at the state level, and even there, of course, it's still a matter of legal dispute as to under what conditions a state. I mean, there can be extraordinary cases where the state can use, its powers to make that happen. But as you say, I mean, history doesn't bear that out in most cases. But can it be done just as a matter of strictly legally speaking in the UK if they wanted to?
Yeah, and it's really across all countries. There isn't really a strong legal reason why that couldn't happen. So I think a lot of the discussions have been about whether it would be legal for employers to introduce mandatory vaccination policy, and also targeting maybe healthcare workers. But to introduce a mandatory vaccination law, that is something that governments can do if they wished.
The conversation here or conversation in the United States has been a lot about universities. Again, sort of here we come back to younger populations, people who might have taken it on board that hey, I don't really need to be vaccinated because I can't get this. I think there's been one university, high-profile university, that's said you have to have the vaccine before you come back. Others have been very reluctant to do that for the many reasons that we've just been discussing. Do you think that's how it's going to play out, almost in a case-by-case basis?
It does seem to be that way. I think if there isn't a government action or policy, individual organizations and private companies that we've seen with airlines announcing that they'll ask their passengers to be vaccinated, like Qantas, I think they will take action themselves, because they see asking for people to be vaccinated as part of being able to carry on with their business, and also as a way of protecting their staff and their customers. So that's likely to be something that we'll see more of.
But say, if you would, a little bit about the immunity passport or the vaccine passport. It's one of these phrases. It got loose in the media, and immediately, I think before people even discussed what it was, it became intensely polarized, and people said, I'll never carry a vaccine passport. And others said, no, you're going to carry it. In fact, you already have to in certain places. To unravel that for us a little bit.
Yeah, I think you're right. The vaccine passports became an issue before they were even an issue. And it's one of these topics that is ripe for discussion about the ethical implications, and it's pitting the individual liberties against the common public health imperatives. So there's a good story in there, and I think that might be why there's been so much interest in vaccine passports. But you're also right when you say this is already existing in various forms, and what a lot of organizations would want, and also maybe governments, would be to make sure this is standardized and is enabled through technology to make it easier to use. For me, I think the distinction seems to be more strongly between a within country vaccine passport and across countries. And within countries, that's going to be more of having access to services and public life, while across countries it's going to be more for travel. My worry actually for vaccine passports across countries is that this may constrain supply to lower income countries of vaccines if travellers are prioritised, and there's just a higher demand for travellers to be vaccinated. And it's also not considering the plight of, say, refugees and migrant workers and asylum seekers who might find it harder to access something like a vaccine passport. So I think the global ethics of such a passport are more of a concern for me. I think that's what I'd see as a major issue that needs to be resolved as these might come out.
I mean, your discussion of that brings me back to your earlier points about your own dissertation work, and then the obituary that I read at the beginning, David Katzenstein, and his later part of his career where he left the US and moved to Zimbabwe, and he wasn't working on AIDS vaccine per se, but it isn't this issue about, so much of the discussion around the vaccination rollout has been about Europe and about the United States, North America. What do you predict? I mean, I guess let me start with a broader question: what is the ethical consideration that we should be having, the conversation we should be having about that there will be an uneven distribution of vaccine around the world? How do you approach that? Because I mean, it's going to be uneven. We get that, but after a certain period of time, it will be available broadly in wealthier countries. How do we approach that question when other countries may not have access, or as you said, migrant workers or refugees may not have access?
I think that there are quite a lot of aspects in there. I suppose what angers me quite a bit is how, I'm pleased that we have vaccines and the scientific endeavor that has produced vaccines, but the fact that they're not all not-for-profit, I think needs to be called out more, and shouldn't be seen as the norm during a pandemic. So there's only 2 vaccines, the AstraZeneca Oxford one and the J&J, that are not-for-profit while the pandemic is ongoing. And for other companies to be having really huge profits while we're facing so many deaths from COVID-19, I think there should be more public outcry about this. It shouldn't be seen as this is the system that we have, and this is the way that we got these vaccines, when many of them were publicly funded. Actually, I saw a preprint today which had found the Oxford AstraZeneca vaccine was 97% publicly funded, which when you see that figure, you realize that it shouldn't be seen as normal that pharmaceutical companies are getting really sky-high profits from COVID-19 vaccines. So yeah, that's one area that I think is very unfair. I think there are many other aspects in the distribution and equitable access to vaccines that you could also call out upon.
Has there been much success historically about raising this kind of ethical concern to drive public opinion to demand that vaccines be made available in countries that are not funding their own national vaccine programs?
I think probably the best example is the antiretrovirals for HIV/AIDS, and having those become available at affordable prices in low and middle income countries was really a huge step forward. But it was just the time that it took for that to happen. We don't want to be waiting 10 years, 15 years for COVID-19 vaccines to be accessible by everyone, and possibly on an ongoing basis. So this is something that needs to be addressed right now, and I think there should be more of a public call out of the pharmaceutical industry.
I mean, I'm glad that you raised it and that you framed it that way, because there's been this slippage to talk about vaccines, to go from COVID-19 to actually talk about the companies and the brands, and to not discover, as you said, 97% of the funding for J&J vaccine, for example, did you say AstraZeneca?
AstraZeneca.
Yeah, 97% of that is public. So you're still, even with that level of understanding, we're still sort of stuck with a nationalism problem and a kind of an idea that, the United States or the UK, we develop these vaccines, these are ours, and if other countries need them, they can get their own. Or doesn't the UN do that? And I'm characterizing an attitude. I don't know how broadly it's shared, but I've heard that discourse that it even if you get past the idea that it's private. You say, yeah, it's a public good, but public good for us and not for poorer countries. They should get their own.
Yeah. Probably one aspect there that I think should be changing sooner rather than later is the idea that surplus vaccines can go to poorer countries. And I think this is just not a fair way of managing the vaccine distribution. I think we need to see more commitment to providing those vaccines now and not just when we're really sure that we don't need them. Because otherwise we're basically sitting on vaccines, we're hoarding them. And it's not going according to need, which especially in countries where very high risk individuals, frontline health workers aren't being vaccinated. I think those need to be the priority now.
Is the discourse of universal human rights useful here? I mean, the idea that a frontline health worker in Zimbabwe or in India should have the same rights, or any person for that matter should have the same rights as someone in the United States or Canada. I mean, to me, it makes sense, but there's a lot of things that make sense to me that don't pan out when it comes to these kind of discussions.
It could be useful. I think actually from my research on neglected tropical diseases, the argument that then went on to work in an advocacy campaign was to make the economic development case for funding action against those diseases and not the human rights packaging or angle. But it doesn't mean that that's not something that would maybe inspire publics and might inspire action. But from that example, maybe it's going to be more about opening economies and making sure that we're not importing cases and having variants. That could be more persuasive.
We're almost up on time here in my discussion with Sam van der Sloot about vaccines and vaccination. Wonder if you just could leave us with some of the things that are going to be on your mind as a researcher going forward here in these next few months. It just occurred to me the other day, I mean, we're right on the cusp of a situation where billions of vaccine doses are going to be distributed in a relatively short period of time. There's so many aspects of that from a research perspective. I mean, to name just one, there's a student here where I am at KAIST who's considering the environmental implications of that. For example, the syringes and all the plastics and everything that goes into that. I mean, there's so much going on just with the supply chain and environment, not to mention hesitancy issues that we've been discussing here today. So you can't tell us everything you're working on, but what are some of the things, or maybe the next thing that you're going to be watching for and researching in the coming months?
Oh, so I think we did talk a lot about the topics that I'm carrying on working on. I'm quite interested in social media discussions about vaccination and how we might learn from those about what kind of misinformation is circulating and also what people's fears and concerns are. So that's one thing that I've been working on. Also, media representation of the different vaccines, safety concerns, or other topics of interest, and how that's being portrayed through the media. So, yeah, I think those are the two areas that I've been concentrating on for the foreseeable future.
Just a reminder, you can catch COVID calls most weekdays at 5:30 p.m. Eastern Time, and join me in my next COVID calls episode on April 19th at 5:30 p.m. 5:30 p.m. Eastern Time. I'll be talking with Hannah Tesler and Mira Choi about anti-Asian racism in the COVID-19 pandemic, and they'll be discussing some research that they have that's just come out on that. So please do join me for that in the next COVID calls. And let me thank my guest today, Sam van der Sloot, for really wide-ranging conversation about vaccination and vaccine hesitancy. Thanks for the work you're doing and your colleagues, and thanks for taking time late at night there in the UK to talk to us about it.
Thanks for having me on. It was great talking.
Stay healthy, everyone. We'll see you next time.